Thank you so much for having me here today. It's such a pleasure to be invited and be able to share my passion in educating the public about how to use medical cannabis. And I wanted to make a special thanks to Allison for organizing this event and introducing me to the Canadian Arthritis Society and allowing me to partake in this and share my knowledge. So a little bit about myself in regards to my background in anesthesiology and interventional chronic pain. This was a very serendipitous shift into chronic pain for myself and to become an expert in using medical cannabis and employing it into my practice. And so today I wanted to share with you an understanding of the endocannabinoid physiology and what exactly is cannabis and how does it play in when it comes to our endocannabinoid system, as well as understanding the difference between cannabinoids and opioids, which Dr. Al-Gabawi had already mentioned, and I'll be able to mention more, and also understanding the risks and manifestation of risks, I guess you could say, when it comes to cannabis. And I know that that had been brought up earlier. And last but not least, basically understanding kind of where the science is, what's going on in the research in regards to where cannabis fits in specifically when it comes to arthritis. And my topic is quite large, and I have a short period of time to be able to share it. And I do have some disclosures for myself. It's an emerging field in medicine, and it's difficult for many physicians to take out time to invest a lot of time, actually, into educating themselves into an area that you've never been taught. Unfortunately, as we all were aware earlier, that our medical schools are not teaching chronic pain management, let alone talking about endocannabinoid physiology. And that's primarily due to drug prohibition, and I won't touch into that too much, but I'm very grateful to be here. This presentation, though, has been developed solely by myself. There has not been anyone, I guess you could say, influencing me in the information that I'm sharing. This has all been independently created by myself and has been peer-reviewed by my colleagues. I wanted to start off about the unsung hero of chronic pain, the endocannabinoid system, and kind of getting a better understanding of what the ECS is. So the endocannabinoid system essentially has been created for us so that we're able to relax, eat, sleep, protect ourselves, and forget unnecessary information. Therefore, its implications occur in pain relief, in regards to mood management, physical movement, as well as blood pressure control, potentially appetite management, our sleep cycles, as well as management of our immune function and our immune system. The endocannabinoid system is a very ancient, ubiquitous system, and we as humans have been using cannabis for more than 4,000 years. And the understanding that I've had as a physician is that we've been interacting with plants for a millennia. And now that we're shifting our understanding and being able to understand exactly what the endocannabinoid system is, we recognize that the ECS is a combination of what we always understood, that there's a receptor, that there's a molecule that binds to the receptor, in this case it's a lipid ligand, and that there's an enzyme pathway that degrades those lipid ligands that are attaching to the receptors, and that in fact that there's possibly a feedback inhibition molecule system we're still understanding. Simply put, if our organ systems made up the body symphony, and therefore looking at the ECS would be the conductor of this symphony. The ECS essentially, as you can see in this image, is related to all types of systems, from inflammation, appetite, memory, regulation of emotions, regulation of our immune system, regulation of our reproductive system. And it's so unnerving for physicians to think, wait a minute, there's a physiological system that we've never been taught, but it's conducting all of this. It's actually involved in every single system, yet we haven't got a clear understanding of this. And for myself, that was a huge conundrum. When I was doing my advocacy work in Toronto, specifically when it came to chronic pain, I came to the understanding that as a physician who was an anesthesiologist and knew so much about physiology and pharmacology, I had such a huge gap in my knowledge. And it forced me to acknowledge my own bias that I had against cannabis, It forced me to face my own stigma that I had against cannabis. And it forced me then to acknowledge that I needed to grow, that I needed to learn, that I needed to improve my own knowledge, because every single day through the chronic pain advocacy work I was doing, there was patients coming up and saying, I have chronic pain and the current solution I have is not working. And I'm interested in medical cannabis, and I would like to know how it works for me, but I don't know who to talk to. I don't have a physician. My family doctor is against it. My family is against it, yet I'm suffering. And this plight of the chronic pain patient is not unique to just Canadians. This is what all North Americans and all humans across the world are facing. And as the shift we are going through in Canada, we are very privileged that we've had a medical system for the last 17, 18 years that was allowing patients to access medical cannabis. The challenge is the physicians, who are the gatekeepers, were unable to educate themselves because physicians are facing their own challenges. As a family physician, primary care, you're facing complex pain, complex health issues, and you're only limited to about 15 minutes to have that conversation. And so to be able to talk about these topics and also acknowledge your own bias, that you don't particularly understand this topic, becomes a big challenge. And I'm privileged to have been able to be a specialist that could dedicate this time and understanding and recognize where I could play a part when it comes to understanding the ECS and how to use cannabis, but also to share my knowledge with larger groups of individuals, because we're all stakeholders when it comes to chronic pain. When it comes to Cb1 and Cb2 receptors, what's fascinating for me is that we actually have a receptor system. And as Dr. Hani had mentioned, the Cb1 receptors are predominantly found in our brain and our spinal cord and our nervous system, which is great because that's also the areas of movement and pain and memory retrieval. Whereas when it comes to our Cb2 receptors, they're found throughout our body. So they're found in our heart, our lung, our skeletal muscle, our reproductive muscle, which are mostly smooth muscle. And when it comes to our immune system, like our spleen and our bone marrow. And because the uniqueness of cannabinoids is that they fit as a lock and key system with these receptors, only cannabinoids can fit into this. And that leads into the concept of, well, what are cannabinoids? Well, we have something endogenous, and endogenous means coming from within. So endocannabinoids, such as anandamide or 2-AG, are what we internally create that bind to our own receptors of Cb1 and Cb2 across our body. When we think about phytocannabinoids, this is essentially cannabinoids coming from the cannabis sativa plant. And this is an important concept because if it's a lock and key component and only cannabinoids can bind to it, then that's a viable option then if we ourselves don't have enough endogenous production of our own cannabinoids, that using a plant-based model may work. And of course, the pharmaceutical industry recognized this right away and were able to synthesize the molecule, and they called it nabilone, or Sesamet as is commonly sold here in Canada. And the synthetic version, unfortunately, in my opinion, doesn't match up to the plant. It has more side effects, the side effects that we're all worried about when it comes to too much THC. And so the rationale behind this then is that what exactly is in the plant? Well, the plant actually has different genuses, one most commonly known as the sativa, the other known as the indica. And the morphology of these plants is very unique. And it's so fascinating for me as an anesthesiologist to be talking about a natural product because that's so far removed from what I've been trained about. But to understand horticulture and understand plant morphology and cultivars is a shift in my knowledge, and it's been very interesting for me. But what I wanted to share with you is that there's different plants have different components to them. We understand that there's cannabinoids, but the other component are also non-cannabinoids. And the non-cannabinoids make up the terpene profile, the flavonoid profile, and other components. And I'm so fortunate to be following the conversation that Dr. Hani had started in regards to natural health products and what their role is when it comes to managing pain. And I'm very interested in the same topic, but in this context, what my natural interest has come to is how do we use the terpene profile in combination with the cannabinoid profile to be able to enhance the care of the patient. Everyone here in the room is like, what is a terpene and what is she talking about? So keeping it very simply, the cannabis plant has a distinct smell. Everyone here knows it smells like a skunk, it smells like diesel, it smells fruity, it smells earthy. Those scents are related to something called terpenes. And terpenes are profoundly found in everything that we have access to. Terpenes are in our shampoo, terpenes are in our cosmetics. Terpenes can be synthesized and added into all things. But naturally occurring, they're also in all types of plants, such as myrcene. And I'll talk about this in more detail later. But the premise behind this is that Dr. Ethan Russo, kind of a neurologist researcher who's very prominent in the cannabis research industry, developed a theory called the Entourage Theory. And I'll go into that in more detail, but the concept essentially is that if synthetic cannabis that we made, such as nabilone, cannabinoid, which will fit into those receptors, isn't working, and most physicians are not using it in their practice because of side effects, then why are millions and hundreds and thousands of people using the plant instead? Because it has the same molecule, and the only rational answer is that there's more to the plant than we realize. And it's the combination of the flavonoids, the combination of these terpenes with the cannabinoids that are giving a better effect. Yet, at the same time, in my practice, I've discovered the distinction that isolating CBD or isolating THC also has valid benefit. But we're in the infancy of understanding this. We have finally been able to reach a point where this molecule is not going to be stigmatized, where this plant is going to be better understood because it's finally legalized. And I admire the progress of Canadians that we're able to enhance this, but we're fraught with questions. We are unnerved by the uncertainty of what this plant can provide us. And I'm hoping that this conversation that we're having here today is allowing you to have more understanding of the topic and also understand its viable role when it comes to pain. So Cb1 receptors and Cb2 receptors that I don't want to go into too much detail in, but essentially the role of cannabis in this case, specifically in cannabinoids, be it THC or CBD or its precursors, are important in neuropathic pain relief, but also nociceptive pain relief. And we covered those topics already earlier. It has a role in inflammation. It has a role in immune modulation. And it also has an interesting effect on muscle relaxation. And because we're discovering that these are all strong components of where pain is experienced when it comes to the musculoskeletal system, then this is an interesting topic to discover and how best to use it. Now, for myself, I've always been curious, how do you actually, understand the value of something when all you've ever heard about is the negative component about it? And for myself to understand CBD and go, wait a minute, all I have ever heard about is THC my entire life, don't do drugs, THC is bad for the brain, and now you're telling me that the plant has something else in it that's actually good for me? And that component is CBD or cannabidiol. And it's considered to be psychoactive, but not intoxicating. And the difference I wanted to point out is that any molecule that crosses the blood-brain barrier is considered psychoactive, which we know THC is. But CBD is psychoactive too because it crosses the blood-brain barrier. The difference is that CBD doesn't have an intoxicating, sedating effect. In fact, it has an effect of improving cognitive clarity. It has the effect of actually improving anxiety. It has a way of improving brain fog in the chronic pain patient. Mechanisms are misunderstood or not even understood because we haven't researched it. But clinically, this is what I've been witnessing. With regards to the terpenes that I had mentioned to you earlier and Dr. Ethan Russo's research, what I have been finding very fascinating in my practice is that the industry itself is recognizing the importance of terpenes. And so here in Canada, with the fact that we have hundreds of licensed producers that are in a billion-dollar industry, making strain after strain after strain, claiming medical benefits, the users, the patients, in this patient-led reform of what chronic pain should be, are the ones identifying what terpenes are much before the scientists, much before the physicians. And now we're kind of catching up. And because the users want to know the profile, the licensed producers are now producing it. Now we're having third-party testing, identifying the concentration of myrcene, the concentration of limonene, the concentration of caryophyllene. And to give you a bit of understanding of how relevant these are, as you can see here on this slide, we're interacting with lemons all the time. It's lemons in our water right over here. And we've always considered lemon to be an energizing component. And so CBD with a higher limonene component, I have found to have more of an energizing component for my patients suffering with pain. Whereas alpha-pinene, which is found in pine needles, eucalyptus, rosemary, has a bronchodilatory effect. So patients who are coming to me and asking, will this work for my chronic respiratory disease? First thing I say is, I don't know, but I'm willing to experiment with you and willing to try. However, we don't have any rules or regulations or evidence around this, but I'm willing to put myself in that uncomfortable position to acknowledge that there's a possibility. Now, beta-myrcene and linalool are the two most common sedating components that are found in cannabis and are also found in lavender and also found in chamomile and lemongrass and hops. And how fascinating that those are also natural things that we as humans have always been using to help ourselves sleep and help ourselves relax. So why is medical cannabis an important consideration for physicians? And this is a very near and dear topic for me. Currently, as of June of last year, and these stats are a bit old now, but 250,000 Canadians are using cannabis through the regular federal Health Canada system. And now with it being legalized, the projection is that in the next 6 years, we're going to be at 500,000 of users. But we are not counting the 500,000 of Canadians that have been illegally accessing cannabis through the black market because they believe it's a medicinal use, but they are claiming it to be recreational. And I argue with them because I don't think anyone really is recreationally using anything. I think we're all stressed. I think we're all tired. I think we all lack a level of compassion for ourselves because we live in a very fast-paced, technologically driven time. And we all are looking for ways to improve ourselves, but we just don't have that knowledge. And for decades, we've been, seduced by drug prohibition and telling us how bad this is because it would destroy lives. But it's been a story that we've been kind of, deaf to, that in the background, there have been people who have actually benefiting from this, and we don't know why. As physicians, as gatekeepers, it's our responsibility to step up and become more educated about a topic that makes us uncomfortable. Because it is very uncomfortable to all of a sudden go from Western medicine and start incorporating Eastern medicine topic into a mainstream practice. And secondly, now with it becoming legal in Canada as of October 17th, there's a need to reduce any risk to the public, and this is the mandate of the government. And I'm in full agreement with it. But how can I possibly know what's wrong with it if I don't even know how to study what's right with it? And that's where I am facing right now to share with you that I have learned the good parts, but I'm open to understanding the bad parts. And if I'm not willing to explore this, then I'm not going to be able to push the frontier in medicine when it comes to inflammatory pathways, when it comes to understanding neuropathic pain, when it comes to self-awareness and mindfulness and understanding how to use that as the proper cognitive tool in chronic pain, because I firmly do believe in that. We're in a position now as Canadians to be able to have a conversation openly. This is such a privilege for us about a topic that has been so taboo. And now researchers and scientists and physicians and hospitals and pharmacists, all the stakeholders are coming to the table, but they need an encouragement because they need people like yourselves to want to improve their lives in a different way and to step away from medications that are harming them. And so we're coming into the topic about what is the evidence around this. And Health Canada acknowledges a wide variety of potential therapeutic benefits for medical cannabis. And some of these have been substantiated with evidence, and some of these haven't. But that doesn't matter, in my opinion, because in my practice, when one person gets the benefit of medical cannabis, that's a real evidence for me. And I can't negate that person's experience. And that's the challenge many physicians face because we start going into this evidence-based model, forgetting about the experiential model. And I'm trying to bring those two components together in my practice. Dr. Hani mentioned the 2017 comprehensive review by the National Academies of Sciences, Engineering, and Medicine. And this is kind of like the textbook that we've been all waiting for, those of us who are interested in cannabinoid medicine, because we were looking for the areas where we could actually do research and discover the areas where there was firm research proof so that we could expand upon it. So the treatment of chronic pain has been proven. It's been proven to help in cannabis for chronic pain. It's been proven. The treatment for chemo-induced vomiting and nausea, it's been proven. And it's been proven in MS spasticity and the pain associated with spasticity. So now where are we going with this knowledge? And the challenge I have personally had is that translating the information, the way Dr. Hani was saying, taking all that information that's out there and then incorporating it and integrating it into my practice, where do I start? How do I decide? Where do I go from here? And one of the things that I learned was that there are really bright people in this world that are putting together research, and they may not have all the funds, they may not have all the people, but they have a hypothesis and they're searching for an answer. And it's my responsibility then to take that information and then apply it, and then out of my own curiosity, see how I can improve the lives of those that I can treat. And so when I came across this article that was actually published 12 years ago, that was the first evidence-based study, and evidence-based means that you're comparing something to a placebo and that you're randomizing it so that you're reducing the biases that could potentially occur in the population, and that you're also preventing both parties, i.e. the patient and the person administering it, from knowing what it was. And also the administration time is randomized. So in that case, then, if it works and it's producing statistically significant results, it's because it wasn't because of chance. Because that's the main thing in research. You don't want it to be because of chance. You want it to be because it's been proven. And in this case, it was a very small study, only 58 people. But in this industry, trying to convince someone to use cannabis when it's not legal, I can imagine it'd be hard to get more than 50 people. So 58 people, randomized, 30 into the group that got the medicine, 27 that didn't. But the results were interesting because they were giving them a spray before they went to sleep, and they were trying to monitor and see if their baseline scores of pain in the morning stiffness would improve, but overall, what would their pain scores be? How would their sleep be? And they used validated tools to be able to measure the outcomes of the pain, and the results were statistically significant. A combination of THC and CBD, known as Sativex, which is produced by a company called GW Pharma, which is a cannabinoid concoction made from the plant, so not a synthetic version. So the closest thing we have to what we have here in Canada in regards to the licensed producer products that we have is Sativex. Demonstrated a statistically significant improvement in pain for those suffering from rheumatoid arthritis, a suppression in their symptoms of inflammation, as well as an improvement in their sleep. Now, what's fascinating for me and out of this is that another group of researchers decided that, they really wanted to know, and every researcher then wants to go to the database that exists to do a review of what's happening. And so a big review was done. And unfortunately, the review said, sorry, not enough studies, not enough proof, not enough evidence, promising, we'll see what happens. Further research is required. Well, thank you. That's exactly where I want it to be. What I wanted to share with you is something recently that I discovered, which I found very fascinating, and that was that there's characterization of cannabinoid, meaning Cb1 and Cb2 receptors, in the synovial fluid in the tissue of joints in patients with osteoarthritis as well as rheumatoid arthritis. Well, how fascinating then, because this was a study that started the topic that maybe this is a direction of medicine that we should be going towards because we actually have receptors in that area where the inflammation is. If we block them or if we improve the quality of pain through using them, is it viable? And I find that very interesting because that's exactly what I've been doing in my practice. I had a hypothesis that inflammation was the cause. And I already know this because we understand that neuroinflammation is a big component of osteoarthritis pain. It was discovered in 1985 that neuroinflammation had a big role when it comes to the inflammatory pathways, and that modulating the sympathetic tone in patients would be able to improve their pain syndrome. And I mean, it was to the point where they were doing surgeries to kind of sympathectomize people in the 20s to prove that they won't have joint pain. So we've been hypothesizing as a species, as humans, that if we reduce the neural inflammation for quite some time, and Dr. Honey was emphasizing this, the reason why we have biologics, I'm grateful that we have biologics, is because we're constantly thinking of new ways to think of pain. And this is the start of what's going on. Now, Dr. Ethan Russo and a good friend of mine, Dr. Caroline McCullum, wanted to put together some guidelines, and so they published in the European Journal of Medicine a practical consideration and guideline for cannabinoid medicine prescribers. And it was so heartwarming to see because, first of all, there was some guidelines coming out there in the context of everyone saying that there was no role for cannabis whatsoever, as per the college guidelines coming out from Alberta, that there was no role in pain, no role in palliative care, no role in anything, it seemed like. To have this was very heartwarming, but what was more heartwarming is I was already doing that, and I got the proof in the literature now to say, yes, Dr. Ahmed, the prescribing doses that you've been using are absolutely accurate. And so moving forward, applying this in chronic pain, why did I choose this? Why did I choose to become so uncomfortable and talk about something that most of my colleagues refuse to talk about? Well, it's because I understand opioids. I'm an anesthesiologist. I've worked in the operating rooms. I've worked in chronic pain clinics. I've prescribed plenty of opioids. I've prescribed every single medication known to us for pain management. And I've always been frustrated that no matter what, I could never reduce the risk of death. Cannabis is the only medication that I can prescribe that has 0 deaths known to man from time on to time now. So if there is a medicine that can never kill you, and I can't say it cannot harm me, I'm talking about death here, mortality, not morbidity, 2 different topics, then it behooves me then to understand it more. It forces me to acknowledge that I need to understand this better because the risks are less. And we're facing a crisis right now. And Dr. Honey mentioned this, and we've got $25 million being invested into sport, and we need that money so we can get to the core of this. But the challenge is I'm at the front line. I'm a grassroots physician working in Airdrie, Alberta, moved from downtown Toronto because I had a passion to help patients that were suffering from chronic pain, had a passion to help Canadians, and realized that Alberta was an area where not enough pain specialists were. Moved here because of these stats, these staggering stats that 2 people are dying every day in Alberta because of misuse of opioids and not knowing how to use them. And I'm not saying the chronic pain patient is abusing opioids. That's not the point. The point is that opioids are highly addictive. And the pharmaceutical industry is finally taking a toll for it because they are the ones who caused this problem by misinforming physicians and convincing us that it was safe to prescribe because the new formula was less highly addictive. So where do opioids play in this role of mitigating harm? Well, in my opinion right now, I don't know. All I do know is that patients who are suffering in pain need a multimodal approach. They need cognitive care. They need rehabilitation. So happy that Trevor was talking about rehab. It is the key to success when it comes to pain management. But when you're exhausted and you're in pain and you can't function and you're on opioids, which make you dull and make you lethargic and give you side effects of drowsiness, sedation, and you're just lying there saying, I know I should move, what are your other options? The gabapentinoids, the amitriptylines, they're all sedating medications because they all work on the central nervous system. They all work on the brain. But we haven't found something that works on the entire body. Oh, wait, but we do. Cannabis. It works on the whole body. The distinction I wanted to make here, because everyone was asking about addiction, and I'm not an expert in addiction whatsoever, and I really can't say I can really share or impart advice on that. but I am facing issues when it comes to opioid addiction in my practice, and I've had to grow immensely to understand how to do deprescribing and do various things. But the difference is that we don't have Cb1 or Cb2 receptors in our brainstem. And the importance of this is that our brainstem is our source of life when it comes to our brain. It's the primitive part of our brain that regulates our respiratory rate, our heart rate, our consciousness, and our seizure thresholds. And it's densely populated with mu receptors, which are the receptors that bind to opioids. That's why opioids are deadly to us, because when we bind too much of the mu receptors in the brainstem, we stop breathing, we slow down our heart rate, and we die. Cannabis doesn't do that because there are no receptors there to bind. Instead, the receptors are in the areas of movement, the areas of memory, and the areas of regulation of movement and memory and thought. There has been evidence in the past with regards to opioids and cannabis use in reducing chronic pain. And this was, again, a multi-center, double-blind, randomized, placebo-controlled, parallel group study. I don't know how good you want it to be, because this is as good as it gets, for the efficacy, safety, and tolerability of, again, THC and CBD extract, also known as Sativex. And the result was, it was efficacious. And the conclusion was, THC and CBD had an independent role to opioids because we were so curious. We didn't even know what it did. We didn't know what it did. Did it make the mu receptor better? Did it make opioids bind better? But the fact of the matter is, it was independent. We discovered that actually the nocturnal pain that patients were having was improving. And there was an actual full modulation occurring, making it that we needed to understand it more. So that randomized control study basically forces us to say, we need to do more research, and I 100% agree. So in 2018, another group came together and said so the same. This time, we're a little bit more finesse. We've got milligram dosing, 27 to 32. It's a bit high in my humble opinion. But the conclusion was, quality of trials were excellent. 15 out of 18 demonstrated that they had a modest analgesic effect, and that 43% of patients had a greater than 30% pain reduction score. That's unheard of with all of my other medications. I haven't had patients say more than 30%, but in my practice I do. And then I found the evidence to match it, and I was like, okay, so I'm not crazy. I'm not going crazy. This is real. And my patients who have been coming to me have been substituting all of their benzos and opioids with regards to cannabis. And this is the crux of our opioid crisis and the prescribing issues that we face here in Alberta. The College of Physicians and Surgeons is monitoring everybody to be able to less prescriptions of benzos, less prescriptions of opioids, less combinations. Well, guess what? Maybe cannabis, especially CBD, can play a role in that as well. So I wanted to share with you some really interesting things from my own personal practice. So I have a fascination with technology. I had a passion to be able to be an advocate. I dreamt up the idea that one day, instead of me pretending that cannabis worked, because of course I had my own bias, that my patients would prove it to me. But how do I collect that data? Well, everyone comes in every 3 to 6 months, and frankly speaking, if you're coming in for cannabis, you're gonna wanna say, yeah, doc, it works, of course, because you wanted more. I get it. But then as a research-oriented individual and someone who's kind of, removed from academics, because I went into private practice, how do I reconcile this worry that people are using me, to get cannabis prescriptions? So the idea was that if you could real-time monitor, meaning that if you had pain and you could document on your mobile phone, because everyone has their phone on them, that this was your pain, and then you use the medicine, and then because we all have push notifications on our phone, check your email, check your Instagram, check your Twitter, those messages come up, then if you got a message from the app saying, how are you doing now? But that time frame was in reference to vaporization and PO taking of the edible oils, which is 20 minutes and 90 minutes. And I'll get into that in a bit more detail. Even though I only have 8 minutes, I'm really going to try to get through this presentation. But the point is that I was so fascinated to be able to have that information, and I didn't know how to get it. So I worked with a company in Stanford. It didn't really work out, so I tabled it. And seriously, I feel so blessed because I was at a big conference last year in Toronto in April, which is the kind of the big conference for cannabis doctors. It's called the Canadian Consortium of the Investigation of Cannabinoids, CCIC. And there was an app going around. And everyone was like, oh, look, there's an app. And I was like, there's an app. I knew someone was going to figure it out. I couldn't, but someone figured it out. Excellent. And lo and behold, they didn't have a medical advisor. And when they heard me actually advertising their app and being like, look how amazing this app is, I thought of this idea of tracking in real time, real proof, real licensed producers. Let's really find out, does sour diesel work for pain? You know, like, what is this? And fascinatingly, I finally got my pilot project, and I'm sharing this for the first time. So in my personal practice, trying to get my patients in, I wanted to point out that, you know, almost 50% of the users are the people you wouldn't expect, 58 to 67. So the baby boomers do know how to use mobile technology. And they were tracking things for anxiety, prevention, and depression. And prevention's my personal thing, because I believe in the combination of CBD and THC, and I believe in using CBD as a prevention of THC psychoactive side effects. And my patients are proving to me that they understand that and that they use that. But this is also what's interesting. 40% of them are using CBD. Only 8% are using an indica. 33% are using a hybrid, meaning that's a combination of the two together. And the top 3 things, but right after it, is inflammation and joint pain. Very relevant. But the reason why my patients are tracking like this compared to the rest of Canada is because I taught my patients how to track it. I taught them that I'm not here to treat your pain necessarily with cannabis. I'm here to improve your quality of life. What are you nervous about? And every single one of my patients say, I have so much anxiety about the pain that I'm anticipating from doing my next activity. The idea of moving is causing so much pain, and the anxiety is making my pain experience worse. So we use CBD to target that. And for those who are having sleep issues, we use THC at night with a combination of CBD to help them sleep so they can have a better day the next day. Whereas the rest of Canada, this is the privilege that I have, we've got over 800,000 sessions. That means that in Canada, 800,000 times a Canadian has punched in their symptoms and management into this app to give us real data that everyone's thirsty for. And I'm so privileged to be part of this technological startup. But joint pain, muscle pain, and anxiety, the top 3 things that Canadians are treating themselves for when it comes to medical cannabis. And the names of these products on the side, I know they sound funny, but the reason why I'm putting them up there for you is that in the other side of medical cannabis, where people don't have a doctor and they're just going and getting cannabis and they've been using it for themselves, and they go to the licensed producers and they purchase it, they're getting Girl Scout cookies, and they're getting Pink Kush, and they're getting this Blue Widow. And in the recreational world, that's what's selling too. So my question is, why are we not allowing ourselves to learn more? Because there's absolutely a value to this. We just don't know how to do so. Now, top symptoms, I was lucky enough to get my team at Strain Print to put together some slides so that I could actually target this audience. So people over the age of 65 are treating themselves for joint pain, insomnia, stress, and anxiety, and monitoring themselves by using this app. Again, the top symptoms being treated for cannabis is joint pain. 12% of all sessions in Canada are being for arthritis. And the symptoms of arthritis are including the following: joint pain, inflammation, joint stiffness, arm or leg pain, knee pain, muscle spasms, nerve pain. However, those who also have arthritis are also saying that they suffer from anxiety, depression, and stress. And we all know that in chronic pain. We know that very well. 1 in 3 sessions treating arthritis focuses on joint pain. This is so important for us to understand. As an observational study, this is the largest collection of data in the world right now demonstrating that users are using cannabis to treat joint pain, and we need to investigate and understand better how to use this. On average, these top treatments, the efficacy is 35%. That's huge. That's huge. I don't even know how to truly interpret these. I need a research grant from Dr. Hani. I have 3 minutes left, and I'm going to zip through this because I want to make sure that I answer all the questions that are going to be asked to me. But I set goals for my patients. Why are we using cannabis? What is the role for this? Oftentimes, it's sleep and quality of life. I always review for substance use disorder, and Dr. Hani is correct in saying that cannabis has the risk of addiction. But the challenge is that we're taking those stats out of context. The comparison of 11% for alcohol, 15% for cocaine, and 24% for heroin. Cannabis is still less than all of that. Less than 10% over 10 years of chronic use. So I understand, it's a worry, I get it, I'm in the same position as the rest of you. However, no death associated with cannabis, less than 10% risk of addiction. But the challenge is, when we talk about substance use disorder, we have to acknowledge that the psyche of that person is different than everybody else. They have traumas, they have other issues, they have psychological problems that are concurrent. And we start labeling people all the time about who's this and who's that, and it's so unfair. And as a physician who is in this realm of compassion and wanting to serve my community, I need to acknowledge that it's not just addiction to drugs that we have a problem in our society. We have an addiction to alcohol, we have an addiction to sex, we have an addiction to food, we have an addiction to many things. And that's a social issue that we're facing. But why are we lumping cannabis into this when cannabis is a medicine? It truly is. I use the lowest effective dose of THC as my mandate, because I don't want to get you high. Now the driving, I don't know what to say. I'm asked every single day. I have my humble opinion. I'll answer that question later when it comes. But mitigating harm, this is the role of physicians. We are supposed to mitigate harm. Are we not supposed to be the experts when it comes to managing pain? So are we not supposed to be the experts in managing the side effects? So cannabis has receptors, cannabinoids have receptors that are also on the heart and on the lungs and on the liver and on the GI tract. So if we have those receptors, Cb1 and Cb2 there, and cannabinoids can bind to it, meaning that the cannabis plant's THC and CBD can bind to it, we should know how to monitor it. Well, as an anesthesiologist, I've been trained my entire life that if you give a medication that causes the heart rate to go fast and causes the blood pressure to go down, the individual with underlying coronary artery disease or heart disease is at high risk of another heart attack. Why is it okay for elderly individuals in Canada to have to go to a recreational store to pick up cannabis because their doctor doesn't want to talk about it, and then they misuse the THC because they don't know any better, and end up having tachycardia, which is a very real side effect of THC, and low blood pressure that could cause them harm, when that could have been reduced if they had been educated that that's not how you take it. But most importantly, it could have been mitigated by giving them CBD instead. So those kind of contraindications and monitors, that's what I do. I sit there and I contemplate and I have conversations to understand, and I educate my patients mostly so that I can also educate myself, because my patients are the ones who are forcing me to acknowledge what I don't know so that I can understand it better. And the key here really is that these are the side effects of THC, and we need to understand them. Dizziness, lightheadedness, the fast heart rate, the perception of time and space become altered. That's known as psychomotor slowing. And then everyone says, you know, euphoria as a side effect. I'm sorry. When did we start thinking that being happy was a side effect? I don't understand this. We give people antidepressants and anxiolytics so that we can make them happy. That's the side effect? No, that's the treatment. So in this case, the side effects are these. The benefits are otherwise. We need to change our language. We need to understand that what we are associating with the euphoria are side effects, and that's actually very true. When you're having symptoms of blurry vision and rapid heart rate, as soon as those symptoms habituate in you, you will feel better, and you actually don't persist in those side effects. The research has been actually proven that once a patient is habituated, and Dr. Caroline and Dr. Ethan did this in their practical guidelines, once you're habituated to THC, you don't get these side effects anymore. And in fact, if you dose with CBD together, you don't get any side effects. But I'm still learning this, and we need to teach this to more physicians so that they understand that even though CBD has a potent analgesic effect, so does THC. In fact, it's even more, because THC directly binds to Cb1 and Cb2. CBD doesn't. It has an interesting mechanism. I'm not going to go into it because it's a little bit over my head myself, but it doesn't directly bind to it. But why does THC work for sleep and MS and all of the muscle-related issues? Because it binds to the receptors directly. So the take-home message in this is that right now, dosing remains highly individualized. It requires a physician to guide you. It requires a conversation to manage side effects, and that we need to understand the method of how we take it. So as anesthesiologists, when I put you under, I give you inhalational gas. And that's because I know that the lungs have a very rapid blood flow through them that allows for the exchange of gas so that I can control the dose of medication. Well, the same concept is applying now in cannabis, because we've understood that the fastest way to get the medicine into our bloodstream and go to our brain is by inhaling it. When we inhale it, it works within 15 minutes. The onset is within 5 minutes. It only lasts 2 or 3 hours, though, which means it's great for an immediate relief of pain. That morning stiffness when you first wake up, if you could take a vape of your medicine before you had to get up to go to the bathroom, would make a world of a difference for patients suffering from arthritis. And this is what I've been able to achieve in my practice by educating and sharing and informing them how to do so, and ensuring them that I'm not intending to get them high. And if they are having those side effects, they need to use CBD right away. Or better yet, we start with CBD and then we vape later. Because the role of the oral medication is it's going through the liver, so we need to have a functioning digestive system. So that's a contraindication if you don't have one. But because it goes through the liver and has to go through digestion, it takes 90 minutes. So this whole concept of edibles and taking a brownie, I don't know what people are thinking. Because really, who has ever eaten a brownie over 90 minutes? Nobody. I know I won't. So we're extracting information and superimposing it and thinking that we know everything when in fact we know nothing. And that we need to be dose controlled, and it takes maybe only 20 milligrams, not 200, which is what some of these brownies are. So as I mentioned to you, the whole point of this conversation is to have an open conversation with your physicians about starting medical cannabis or finding a specialist like myself who is interested in sharing my knowledge with other physicians to empower them to be able to incorporate this into their practice, and that it's not as difficult as it seems, and that we create more patient populations that are using this as a medication so we can understand it better, so that we know how to reduce the risks involved, so that we can understand how to prevent harm. Because if we don't, then we're stuck in the dark ages. And unfortunately, we're going to become, I'm very concerned about, a population that misuses cannabis, and then we have another crisis 30 years down the road. I don't know. But what I do know is that in the current state, that if a plant that we've used for 4,000 years has yet to ever kill us, and that thousands and thousands of people have used it without any negative consequences, and have found the benefit of it because we have a system in our body that actually regulates and monitors and adjusts it, then it is an important thing for me to learn so that I can help my patients get better care and improve their quality of life, particularly when they're suffering in chronic pain. Thank you so much. I really appreciate it.